Welcome to this ESO-WSO meeting 2020. This meeting was initially planned as an in-person meeting in Vienna and has now changed to a huge and highly successful virtual meeting. My name is Stefan Kiechel. I'm working at the Medical University of Innsbruck in Austria, and my interview partner is William Whiteley from the University of Edinburgh. He is epidemiologist and clinical neurologist. He is also affiliated to McMaster's in Canada and to the University of Oxford. Will, congratulations to this new exciting findings from the long-term follow-up of Ascot, which is one of the seminal statin and blood pressure trials of the 90s. Could you please briefly summarize the research questions that you have addressed and provide some methodological details and, of course, the key results?
Thank you, Stefan. So the Ascot study was a large randomized trial looking at different methods of managing blood pressure and different methods of managing LDL cholesterol. And so it took patients who are hypertensive with a number of vascular risk factors and randomly allocated them to either an amlodipine-based blood pressure regimen or an atenolol-based regimen. And in those with a higher LDL cholesterol, randomly allocated them to atorvastatin or to a placebo. And this study was started 20 years ago and ended active follow-up about 5.5 years after it started. What we sought to ask was whether the management of blood pressure with an amlodipine-based regimen or management of LDL cholesterol with atorvastatin over the trial period led to a reduction in the incidence of dementia or stroke over the subsequent 20 years. And the way we did that was by taking the identifiers from each of those participants in the United Kingdom and linking them to United Kingdom health records at a national level to see who got dementia and who had a stroke over the period of follow-up 20 years later. Now, that limited in some ways the information we had about the participants for those 20 years, but does give us an important period of random allocation, potentially allowing us to draw causal inferences. So what did we find? Well, there are about 8,580 participants in the United Kingdom, and many of them had stroke during follow-up, and those participants allocated to an amlodipine-based regimen had a significantly lower incidence of stroke over that entire period. But we didn't find any difference in the incidence of dementia 20 years later. Those allocated to atorvastatin, although at the end of trial there was an important difference in stroke incidence, that wasn't sustained up to 20 years. Of course, from 3.3 years to 20 years, we had no influence on people's management of atorvastatin, and we found no change in the incidence of dementia. So those are the key results. We also used this trial as an observational cohort, and we found that those people who had a higher blood pressure variability had a higher incidence of dementia by 20 years, but we didn't find any difference with mean blood pressure or mean LDL cholesterol. Those people who had a stroke during follow-up were at higher risk of having dementia afterwards, but again, just an observational analysis. So I think the important findings really are that management of blood pressure with an amlodipine rather than a atenolol-based regimen led to a lower incidence of stroke up to 20 years later. I think that's an important finding. And second, I think there's a something methodologically important, which is that linkage to large-scale national cohorts, large-scale national records is an important extra string, if you like, in the bow of the clinical trials.
Yeah, well, the data about blood pressure are really impressive in my view. That means that a blood pressure treatment of no longer than 5.5 years and lowering by no more than 3/2 millimeter mercury is sufficient to confer long-term protection against stroke. This underscores the importance of hypertension as maybe the outstanding risk factor of stroke. What is your implication for the clinicians?
So I think for clinicians, I think the first thing is to emphasize the importance of blood pressure in stroke prevention. So we should think of every time we see a stroke patient, looking at their blood pressure results, discussing blood pressure with each patient, and perhaps the fact that we still see a difference in the incidence of stroke 20 years later in those people who, if you like, started on a more effective regimen, or at least a blood pressure regimen with amlodipine rather than the tenolol, we still see a difference. So there's a good reason to start early, because starting late is not necessarily, is still going to lead to problems over that period. So I think blood pressure is the key. I don't think that the implications of our trial is that there is no effect of atorvastatin. It's simply that the period of atorvastatin was short, and we didn't detect a legacy effect, but we know that atorvastatin does reduce stroke incidence.
Mm-hmm. Yeah. My impression is that most neurologists are now experts in secondary stroke prevention, but, and this is quite paradoxically, only few of them are involved in primary stroke prevention. Do you think that neurologists should play a more active role in primary stroke prevention as well?
Well, I think that really depends on what kind of health system you work in. So I know predominantly the UK system, where most primary prevention is done by primary care physicians or general practitioners in our case, and general practitioners by and large do a good job in doing that, but there's always room for improvement. So in a system like ours, I think the role of stroke physicians and neurologists is to continue to educate our primary care colleagues about the importance really of stroke, and emphasising the bad things that can happen if blood pressure is not well measured. In other systems, of course, where a neurologist might be a primary carer of patients, that may be the case in other European countries, then primary prevention is going to be important when they're looking after patients with other conditions, for example, migraine, multiple sclerosis, and others.
Yeah, thank you for these clear words. Let's proceed to the negative findings. In well-designed studies, interpretation of positive findings usually is straightforward, but the interpretation of negative findings always is challenging. You did not find an association between blood pressure lowering or statin therapy on long-term risk of what you have called recorded dementia. On the other hand, we now have very large meta-analysis showing that efficient lowering of LDL cholesterol by statins and efficient blood pressure control do have positive effects on dementia. You have contributed to a recent meta-analysis published in JAMA on the issue of blood pressure and dementia. Would you please share your thoughts about this discrepancy? What are the reasons why in Ascot there was no association with recorded dementia?
So I think the period of intervention was short relative to the period of follow-up, number one. Number two, the way we detected dementia was in people who were hospitalized with dementia. That probably detects someone who has dementia over their lifetime, but we didn't use more sensitive measures. And actually that's very difficult to do at scale. Thirdly, I think the effect of blood pressure on dementia incidence is very small if it exists. And I think that the meta-analysis that was led by our colleagues in the University of Galway did demonstrate a small effect over that period, but it wasn't very large. And then we don't know much about people's blood pressure management after the end of the trial. So there are a number of reasons, some of which are related to design, some of which related perhaps to the true effect, which I think is actually very modest.
Yeah, thank you very much. So to summarize, the key message is that blood pressure is one of the strongest risk factors of stroke, and one should start lowering blood pressure as early as possible in midlife, like your Ascot data have shown, but maybe even earlier in early adulthood if blood pressure is high at this age. Yeah, well, thank you very much for this interview. And thanks to everybody who took time to listen to this interview. See you online during this great virtual meeting. Bye-bye.
Bye, Stefan. Thank you.
Bye.